Hello, my name is Ariana King, and for today's special topics presentation, I will be talking about Epidermolysis bullosa. Epidermolysis bullosa is a group of genetic diseases that affect the skin. Abnormal fragility of the skin results from skin separation between the epidermal and dermal layers. Its primary feature are blisters that usually form in response to minor friction or trauma. However, the severity of the disease can proceed to life-threatening severe scarring. The fundamental abnormality in this disease is an increase in collagenase activity, which leads to collagen degeneration and thus the splitting of the various epidermal layers between the epidermis and the dermis. This disease begins at birth and can be inherited either recessively or dominantly. The more severe forms are recessively inherited. This disease affects 1 in 17,000 live births in all races, with an estimated 500,000 cases worldwide. And although there are more than 20 subtypes, there are 4 main types of EB. EB simplex, junctional EB, dystrophic EB, and the fourth, which is Kindler syndrome, all of which range in severity. All forms of EB result from the genetic mutations in the KRT14 and KRT5 genes that encode for the formation of structural proteins or basal keratinocytes at the dermal-epidermal junction. Fragility in more severe cases can also extend, in some cases, to the mucosa and the eye. Anesthesia is frequently required in this patient population for dental extractions because these teeth have an ectodermal structure similar to the skin. Therefore, the disease affects the enamel and increases the susceptibility to dental caries. These patients are also often in need of surgery for the removal of scar tissue, relief of oropharyngeal strictures, or correction of pseudosynodactyly. Often, esophageal dilations may be needed for scarring from blisters in the esophagus. These pictures are very difficult to view, but I believed were important to include to show the depth of the severity that this disease can manifest. As you can see, oftentimes the fingernails and toenails are missing in these patients. Renal insufficiency, porphyria, anemia, and malnutrition, and protein losses from exuding lesions may also accompany this disease. On another note, porphyrias are a group of inborn errors of metabolism characterized by the overproduction of porphyrins. Only acute forms of this disease are relevant to the management of anesthesia and can result in life-threatening reactions to certain drugs. Drugs may trigger an acute attack of porphyria by inducing the activity of ALA synthetase or interfering with negative feedback on the final common pathway. Although you cannot completely predict which drugs may be harmful to these patients, barbiturates and certain steroids should be avoided. Anesthetic considerations. Meticulous attention must be paid to positioning, monitoring, airway management, and infection control when caring for these patients. Have the patient move to the OR table themselves, therefore minimizing minor friction. Ensure all sheets and padding are free of wrinkles and folds that could produce pressure points. All anesthesia equipment touching the patient must be lubricated and/or padded with cotton padding, such as cotton padding underneath the blood pressure cuff and lubricated EKG pads with cotton padding wrapped around each cord. Even the cuff on the O2 mask must be lubricated prior to application. The use of an oropharyngeal and nasopharyngeal airways should be avoided, and the ET tube size should be smaller than that is recommended and well lubricated. IV access and/or arterial access should be secured by means of an elastic bandage. For patients with an anticipated difficult airway, or an easy airway rather, deep sedation with a local anesthetic is the recommended practice. Regional anesthesia is a good alternative, but care must be taken when disinfecting the skin at the site. Rubbing should be avoided, and local infiltration of the skin should not be performed. This technique can be supplemented with IV sedation. A difficult airway may result from perioral scarring that can restrict the opening of the mouth. There may be adhesions in the larynx and on the tongue, which may lead to distortions in anatomy. Bullae formation in the oropharynx may present from previous airway instrumentation. For those with anticipated difficult airways, awake fiber optic intubation is the safest option for airway management. This is less traumatic to the mucosal epithelium than direct laryngoscopy and should often be the first choice in the EB patient. Depolarizing muscle relaxants are controversial, as it has been implicated that fasciculations can cause skin damage and hyperkalemia could occur due to the muscle wasting that often occurs in these patients. And of course, be sure you do and practice careful eye care. Eye ointment and lubricated eye pads are necessary. Do not use tape. As previously indicated, laryngoscopy, endotracheal tubes, EKG electrodes, face masks, blood pressure cuffs, LMAs, and any type of tape can induce blistering, infection, and scarring with these patients. Oxygen masks in post-operative recovery unit should be avoided, as sharp edges on these devices can damage skin. Prophylactic antiemetics should be administered, as well as adequate post-operative pain control. Post-operatively, pain control is very important as to prevent thrashing in the bed, or for the pediatric patient, the crib. There is no cure for any form of this disease. Mortality rates vary with the severity and therefore the type of disease. With the more serious form of junctional EB, mortality may be as much as 47% in the first year of life. Treatment often includes corticosteroids to limit scarring and the use of phenytoin to reduce collagenase activity. There are also recent gene-based therapy options, as well as protein-based therapies that have achieved some success. However, the most important treatment is the avoidance of any type of trauma to the skin or mucous membrane. Careful hygiene is important to minimize the risk of infection resulting from scarring. In conclusion, epidermolysis bullosa is an abnormal fragility of the skin that results from the skin separation between the epidermal and dermal layers. It is a genetically inherited disease that affects 1 in 17,000 live births, with an estimated 500,000 cases worldwide. These patients often need surgery for dental procedures, the removal of scar tissue, relief of oropharyngeal strictures, or correction of pseudosynodactyly. All types of friction should be minimized during the perioperative experience with the least invasive anesthetic technique. Thank you.